Thank you very much for agreeing to answer a few questions today at the UK Forum Education Day for MDS. So can I ask you to state your name, your hospital, and the title of your talk first, please?
So I'm Dr. Simon Staworth. I'm a consultant haematologist. I work in Oxford. I have a joint position between Oxford University Hospitals NHS Trust and NHSBT, the Blood Transfusion Service.
And the title of your talk was Towards Optimal Transfusion Care in MDS.
So I was talking today about how we give transfusions, blood transfusions. So as many of us are aware, blood transfusions are still a very common part of how we manage, how we support these patients with bone marrow failures, where their bone marrow, where their factory for making red cells isn't making them as well as they used to. And we're particularly wanting to support the anemia, the lack of red cell production. However, how we've been giving these blood transfusions hasn't really been studied in any particular way. And so one of the purposes of the study that we discussed at the meeting today was a first study aimed at trying to understand slightly different ways of giving red cell transfusions to patients who are dependent, who require regular red cell transfusion support.
Great. Why was the study conducted in the first place? And the trial was called REDS, I believe.
All studies seem to have acronyms. They seem to have ways of looking at changing a very complicated long title into something shorter. So I should know this, but I think RED stands for red cell transfusions.
We'll come back to you on that one. But why was it conducted in the first place?
We did it because we wanted to do a study to explore different ways of giving red cell transfusions. And in particular, we're aware that some groups of patients might benefit from having less transfusions, and it might be safer not to give transfusions if you don't need them. But other patients might benefit from slightly more transfusions to keep their haemoglobin a little higher. So this starts to raise the question about, well, which approach is a better approach? And because this hasn't been studied before, the study that we undertook was what we would call a feasibility or a pilot study. Can we get a study to work? Can we get it to work in practice? Is it something that's acceptable to patients? And is it something that the doctors and the nurses looking after these patients can also follow up on and give to their patients? So it was a small study aimed at exploring the differences between these two approaches to transfusion.
Great. And what can you tell us about the potential on cost effectiveness, or might this study have an impact on the finances allocated to blood transfusions?
I think it's important to recognise, as I said, that this is a small study. We're completing the analysis at the moment, and the main results for this will be presented at a big international meeting at the end of this year. But one of the results which are presented today started to say something about, yes, it is feasible that we were able to use this transfusion protocol and give the transfusion protocol in two different ways. So I think some of the main achievements of the trial were very positive. One of the other findings was that we need to understand how many extra transfusions need to be given. What's the difference in the number of transfusions between these two approaches, between these two protocols? And that's important because, as we all know, we're working in an environment where we have to think about costs, we have to think about the most effective way of looking at costs. So if there is a difference in how we use transfusions between these groups, we need to think about all the implications. So for example, just providing a bag of red cells to someone doesn't, in a hospital, fails to perhaps capture those costs that might be part of the blood bank, the storing of the blood cells, the processing of the blood. So all these things would need to be thought about.